Thank you for the introduction, and thank you, Megagen, again for inviting me to speak. I never turn down an invite, especially to Dubai, and especially from Megagen, of course. So, just a little bit about me. I work in central London, in Fulham. We set up a practice on the high street. Oops, sorry. I work in the City of London as well. I work in a couple of clinics, and not too dissimilar to the skyline in Dubai here, but you have very nice views. Sorry, this is going forward too much. You have very nice views from your practices, I'm sure. You probably have a view like this from most of the clinics in Dubai. This is the view from my clinic. There's a lot of traffic and buses and stuff like that. It's good for business because they pass by your clinic and they sit and look inside your clinic. This is where I work, in Fulham Palace. So if you visit, go and visit. Forget about Hyde Park. It's big, and this is a nice park on the river, really worth visiting. And my wife is a dentist, Dominique, and I have 2 boys, and we qualified together. And I wouldn't be here today without her help in letting me continue my career. So, I mean, Omid's lecture couldn't have fitted more perfectly. Omid, thank you very much, because every single point he went through, there was a lot of mistakes with previous research. As you said, I'm not going to go through every one of them, but this in the past used to be a success. They basically, as long as the implant was in and it was functioning, the aesthetics was secondary back in those days. And there was a lot of problems with the studies that were shown. I don't know why this is skipping too much. We had the wrong implant size, okay? Omid mentioned earlier about implants being too thick and wide, which is one of the reasons why we had failures. There was the wrong connection. We didn't have platform switching connections back then. Wrong positioning. We used to put the implant into the socket. Now we know that we need to put it more palatal and deeper. Wrong size of implant. Wrong biotype. We didn't assess, did we have thin tissues or thick tissues? Wrong flap design. We used to raise flaps for everything. We know now that raising flaps obviously causes a recession. No bone graft. We used to just put the wide implant in and just leave a space in the gap. We didn't do any soft tissue grafts back in those days. We didn't do provisionals. We used wrong provisionals that were too wide. And there was no such thing as socket shield. So, and I think this is, I'll show you now, I think this is where we're heading now. So, we get to this situation. Which one do you think the implant is in this situation here? There's always a telltale sign of something that's not quite right that tells you which is the implant. So this looks like an almost perfect result apart from the papilla here. And we all, sorry, this is going a little bit too fast. So you can see here, the papilla actually was here from the start. It's not like we did the implant and it receded. It was like that from the beginning. So like you said, you always look at, you know, when I saw this, I thought, why is the papilla like that? Maybe I put it too close to the tooth next door. Actually, it started like this. So sometimes don't beat yourself up too much about the final result. I think it's not reaching... So we all know that planning for implants is restoration-driven. You start with the final result and you work backwards. We all know that to be the case. One thing that there's always been a little bit of debate about is whether you do the implant delayed or immediate, and we know from the beginning we used to do the implants staged. Maybe if we get another... Yeah? Thank you. I'll just change this quickly. Yeah, so the timing was the next key issue. So we started off by doing delayed placements. We used to wait 3 months in the mandible, 6 months in the maxilla. Then we went to early placements, waiting 6 to 8 weeks. Obviously, immediate placements with plus or minus soft tissue and bone grafting. And then we're now onto socket shield. And depending on the site, when you classify the site, depends on which one of these options you may go for. So we already mentioned the extraction site problem. As soon as you extract a tooth, many studies have shown that literally within 8 weeks, the buccal plate is lost, okay? Which means that if you don't rebuild the soft tissues and the hard tissues, you're going to have a compromised positioning of the implant. And you end up with this scenario. So the question is, implants in the aesthetic zone, do we preserve or redevelop the implant site? And my answer to that is definitely, obviously there's lots of questions to answer, but definitely my preference is to preserve from the start by putting in the correct provisional and leaving the soft tissues exactly as they are from the beginning. So preservation is key. One time I was there was a conference in Scotland. I was lecturing, actually just on the Megagen stand. I wasn't lecturing in the conference theater, but they said, could you do a little presentation? So you can see here I was asking the question to flap or not to flap, similar to what you were showing, Omid. And my next slide, we were talking about this, and I don't know if any of you can see from that far. Can you see who this is? Danny Boozer, so a little bit close up. And you can see the slide behind me. Do I preserve or do I regenerate? And he was looking. All of a sudden, I saw in the corner of my eye Danny Boozer standing there, and I was saying the opposite of what he usually says. So I nearly choked and started stuttering a little bit, but we had a chat afterwards, and it was quite fun. But they are coming round. This was the photo I showed you at the beginning of the case. And we went from there to there. And we just have to do some papillary illusion. If you get everything else right, the color and the chroma and the shape and everything like that, this becomes not very significant. The patient didn't even notice. It was only me looking at my photos afterwards that I noticed myself. And then when you look at the photo at the beginning, you realize there was an issue to start with. So we took the tooth out. So this was done, no socket shield, no soft tissue grafting, and we got a really good result at the end. But look at the issue here. Look at the soft tissues on the tooth, which is nice and curved, and look how flat it is here. With no, I always put something in the jump gap, but no soft tissue grafting and no socket shield. So it looked like a perfect case, 99% perfect, but when you look like this, you start wondering, how long is this going to last without it resorbing even more? 9 years down the line, 10 years down the line. So it starts making you think. And what implants like is this. They like to have this amount of soft tissue. Okay? And you look at the contours, they usually say around 4 millimeters of bone between the face of the implant, the labial face of the implant, and whether that's 1 millimeter bone, 3 millimeters soft tissues, or 2 millimeters bone, 2 millimeters, you need at least 4 millimeters of buccal tissues. And this is a case, this is how I traditionally used to do all my implants, like this. We'd start off. This is non-guided, just with a stent, but we make a provisional with a hole in it just to allow me to place the implant in the correct palatal position. And then sometimes I get a connective tissue graft from the palate. Sometimes I just try and dissect a little bit out from here and get a small amount of connective tissue from the palate, so it's just one surgical site rather than two. I always fill with bone, and you can see we're keeping the soft tissue profile. and then an immediate temporary provisional, and we just mark down the gum line here when we're trying it in. The graft that I took out, we literally de-epithelialize, or if it's already de-epithelialized, we attach it to this area here. And then in our provisional, you're planting a seed. You know, you just need a little bit, a small sort of circular bit of gum, and you're planting a seed where it will grow over time. So we put this on the inside, suture it into place. And you see it sits literally on the inside of this area here, in the most important, because you want this sort of bulge in your final result. So right in this position is where you put the soft tissue. And then in your provisional, temporary, you create a little bit of a space. You don't want this you want to sort of ovate, you don't want it sticking out too much. You don't want like a concave surface. So you create a little bit of a depression where your soft tissue sits here, and that's where you don't want it pressing too much on the soft tissue. That's how it looks immediately with the temporary. And you can see after healing, we've kept and maintained and maybe even augmented a little bit the soft tissue profile. And this works. It works very well. And then as we know, we take temporaries, customized impression copings, zirconia. I don't like full zirconia abutments. I like hybrid ones, and metal-free crowns. And we get a nice result. This patient didn't want to do anything else similar to yours. They guide us into what they want. I would have loved to have done something and changed even just the crown on this tooth, but they were happy as they were. So we know that we are more predictable in our immediate implants with what we know now, using the right implant and what we know about grafting and soft tissue and filling the gap and not raising a flap. With all these things, we can get very good results with immediate implants. And sometimes, you know, you just have to think a little bit laterally. And in this case, we took the tooth out, and actually we used the tooth as the temporary. We actually made the existing natural tooth, we made it a screw-retained temporary. So just shaping the tooth, we hollowed it out inside. As you can see, we actually converted it into a screw-retained tooth. And we used that as the temporary. And it was meant to be as, you know, just a temporary tooth. But we're now, I think it's 3 years down the line, and the patient doesn't want to change the tooth. She knows one day she might have to, but I've asked technicians if they would, that's how we started. That's it at the immediately after, and then this is it at 2 weeks. So patient to have that after 2 weeks of having the implants, she just doesn't want to change it. And even technicians don't want to take the case on because they're worried that they're not going to get as good a result as her own natural tooth. So we'll see how it goes. And that was results. And I think now we're at the 3-year mark. And then we get to socket shield. What's socket shield? You know, when I first heard this, I thought I Googled socket shield. The first thing that came up was this. It was a socket and the shield that covers it, so you don't have kids playing in the socket. And then basically started reading about it, and it's just a technique that's used in implants where it's demonstrated just the potential to preventing the buccal plate from collapsing. It makes the body feel that the tooth is still there. Whether you have 1 millimeter of the tooth left or the whole thing, the body still thinks that the tooth is there. The periodontal ligament is still there, so there's still blood supply. And especially if you don't raise a flap, you have the blood supply from the facial tissues as well. But people start sort of saying, well, how can it work? It just goes against everything we've been taught to think. But we know from the 1950s that retaining root limits the alterations. We used to submerge roots, actually, when we were advocating beneath dentures. So you don't have the ridge just shrinking away if you extract everything. So we used to leave some roots in so that you can have the ridge preserved for an overdenture. This is before implants were even around. And we know that in 1984, there were some studies to show by Malmgren that bone can actually grow, if you submerge the roots enough, the bone can grow over it, which is a sign that actually the body can heal over the existing tooth. And we know from more recent studies by Salama and his group that we can use this for pontic site development. So if you're even underneath bridges, you can leave the root in. And then we think about coronectomies. How many times do we take, if there's a risk with the nerve, where the roots of the tooth are overlapping the nerve, and you warn the patient and you do a coronectomy, and it seems to work as well. So you just cut the crown off the tooth, leave the apical part, and everything heals up, and things sit there very happily. So we've been doing that for a long time as well. So, like I said, socket shield eludes the body from realizing the tooth has been extracted and circumvents the normal events that happen during healing, which basically is the resorption of the alveolar of the buccal plates. So, but who invented the idea? A lot of people say it was Howie Gluckman's invention, the Maurice Salama's group, Otto Zohr and Mark says there's different groups doing the socket shield technique. But actually it was invented by this guy here, Konstantinos Siompras, a Greek guy. The only problem is, the reason why he's not well known is because he doesn't speak a word of English. So unfortunately, I met him in Barcelona a year ago, and this is Mitzias Miltiadis, who's actually lecturing at the Las Vegas meeting. Who I suppose he's his protege. Has been working with him for a long time, but he was the first guy that started doing it back in 2006, and I had the privilege of meeting him, and he's a lovely guy. So I suppose it was the Greeks that invented a lot of things, and they invented socket shield as well. So he started doing it back in 2006. And the first socket shield publication was by Hertzler. This is why a lot of people think that Hertzler's group actually invented the technique, because they published on it first. He was sitting very happily in his clinic, just getting along, doing these cases, getting good results, and he actually didn't publish anything. He was just working in his clinic, and Hertzler and Zohr published first. Then a few years later, another publication by another group, Baumer et al., 2014, first group membrane publication came out, which was actually the Greek group, and they published 5-year data. The first step, they started inventing a protocol, and there were different protocols of how you should prepare the socket shield. Marcus Hertzler started off by doing the technique, which is drilling through the tooth and preparing the osteotomy with the tooth still there. They later realized that actually that creates forces on the actual tooth and the buccal plate, so they abandoned that technique. Then they did some volumetric studies, and then more studies by Mitzias, which is who works with Siompras. We now have 10-year data on socket shield. I then met Howie Gluckman, and I was out in South Africa lecturing last year as well, and we had a good time. But there's still a lot of negative feedback, especially in the UK. I don't know what it's like other places around the country, around the world, but in the UK, it's still considered like they're not comfortable doing it. And they say, well, even Howie Gluckman, and they published a paper, they had 20% complications, or they actually think it's 20% failures. When you actually read the studies, any study you see, you have to read into it and see what they're doing. But they basically did a retrospective multi-center study, so there was the Salama's group and Gluckman, and it was in a few clinics, and Jonathan Dutoit. And basically they placed 128 socket-shielded implants, and they had 25 that weren't failures, they were just complications. There were 5 failures out of 128 implants. The remaining failures or the remaining complications were just managed and just observed. And the complications were that they left the roots, the fragment of root, they left a little bit too much. So when they took the temporary crown off, there was exposed, and they just had to shave a little bit down. So there were just complications that they managed very simply. We also now have 5-year histological data by the Greek group, which shows that actually leaving some tooth fragment and leaving a space between the implant and the tooth fragment that you've shaved down, you have bone growing in between. And again, this is one of the reasons why the AnyRidge implant is perfect for these cases, because again, there's the chamber concept, wide threads, narrow core body. You don't want an implant that's just parallel walled with thin threads. So it makes this implant perfect. So we know this, they give it different names: socket shield, partial extraction therapies, root membrane technique. It's pretty much all very similar. But I just couldn't get my head around when to start doing it, because I didn't want to do it on a lady with a high lip line who's just really concerned about aesthetics. So I waited and waited and waited until I found this guy was referred to me, and he came in, and he's been living with this dark tooth his whole life. He was about 55 years old. He didn't care about aesthetics at all until he fractured his central tooth, and a dentist referred this to me. They just temporized it, and I thought this would be the perfect case that I could try socket shield on. So this was my first case about 3 years ago, and we prepared the socket shield. So that's the start. We started preparing it, and at the time, I had to use any burrs that were in my kit. I just started finding some long burrs that I could use, some burrs that I could shape. Now, I'll show you later, we actually have a kit to do this that Megagen have made. So the socket shield was prepared. We start preparing the osteotomy separately. We shape the shield in a crescent shape. We place the implant, leaving a space between. We graft the area with bone. I wasn't temporizing this with an immediate temporary. I was a little bit worried, and my first case, I did a soft tissue graft, and we just, usually with my soft tissue grafts, I give them an Essex retainer just to cover the palate so it's more comfortable for them. And we stitched the graft in place, just made it a little bit longer. We tucked it into the buccal, and you can see here, implant was in, and I thought I did a really good job until I took the x-ray. And you can see exactly what I've done here. So you can see here the root. I left the apex of the tooth there. And I thought, great, this is my first case, and it's going to not work out. And I was panicking a little bit. Actually, and then we just did a cantilever temporary just to help. And actually, it worked out really well in the end. So we then added zirconia abutment. You can see the soft tissue, everything is held in place. And the only problem was that this was obviously restored by the referring dentist. And if only they had done some bleaching on that tooth, it would have really finished the case off quite well. So you can see this tooth is very dark, but you can see the maintenance of the soft tissue profile and the aesthetics around the implant here. Now, this was immediately afterwards, and zirconia abutment. So I'll just show you. This was at 3-year follow-up. This is my longest case, and you can see the results. So sorry, these photos were sent to me by the dentist that restored it when they reviewed it at 3 years. So I think they're taken with an iPhone or something, because they're not very clear. But just want to quickly, I lecture a lot on teeth whitening, and how many cases do we get with a dark central tooth like this? And sometimes it has a fiber post in that you don't want to go in there and do internal bleaching. So there are other ways of treating these dark teeth by a technique I developed called core bleaching. So what you do, and I'm not going to go into it too much, but what you do is you have a dark crown already with a post in. So you're not going to do internal bleaching. So when you prepare it for the crown, you use the crown as the temporary that you insert the gel into, and the patient changes the gel every 2 or 3 hours. They take the temporary crown out, they squeeze the gel inside, put it in, leave it in for a few hours, take it out, squeeze it in, and the result you get, wouldn't your technician prefer to do a crown on this tooth rather than this tooth? Okay? So again, it just helps the aesthetics of the final case. And you saw from the previous one, the crown on the left central was a little bit gray. The nice thing with this is that the gel works beyond where you put it. So actually, it whitens the remaining root surface. So you don't get that grayness underneath the gum as well. And then you obviously do the crown and you complete it in place. This is another case where we did this technique, and you can see, look how dark this central tooth is here. So rather than leaving it this dark, you do the core bleaching, and it goes from that to that. And you know how long it takes? 3 days. So I don't leave the crown on for weeks until the crown is ready. It's 3 days, it's ready. Then you can cement the temporary crown on with temporary cement or whatever you want. Anyway, if you want to know a little bit about that, you can speak to me later about it. And the nice thing with Megagen is it's a company that, you give them an idea and they think, actually, that's a really good idea. And they were the first people to jump on board, and they just made a root membrane kit. And since using this, it's so much more simplified. The burrs are perfectly made step by step. You have step-by-step protocol of how to do this. And we'll show you a little video of how this is done. So I'll just go through the steps that this kit does. So first thing you do is you get a Gates-Glidden burr and you remove the GP. So you decoronate the crown, remove the GP all the way to the root's apex. So obviously you take measurements. Then there's the initial shaper burr, which goes halfway up, and you go mesial, distal, until you almost break the contacts. Then you use the same burr. It's got markings. You go all the way to the apex until you get this sort of shape. You're going mesial, distal. You then remove the palatal fragment. Then you have the next burr, basically shaving it down to the desired width. And you go again all the way to the apex. You then have a wider diamond burr that you reduce the fragment that's still showing, and you reduce it all the way, again almost down to the crest of bone. And then this burr just cuts on this plane here, and this is what takes it down to the bone crest. So it doesn't traumatize the buccal soft tissues. And then you have another burr that just bevels the margin. And then the final burr is just literally just to mark where you're going to do your osteotomy. And then you start using your burrs to actually prepare for the implant. So there's nothing touching that root fragment at all. If you use these burrs to touch the root fragment, it's going to vibrate, it's going to shake the buccal plate, and we all know, as Omid said, this is often less than a millimeter thick. And then this final burr, if it's very dense bone, just so that your implant doesn't get deflected forwards, it just prepares, it bevels the platal bone, and then you insert your implant and temporize. And that's what you should see at the end. If you have something like this, and the buccal piece of bone is moving, and you can even see the buccal plate moving, that is not a case that you try socket shield on. So always test, even when you've prepared a socket shield, test and make sure that it's actually firm and nothing is moving. If it is, you've got to take it out. You can't leave it in. So this case, lateral incisor, we did a socket shield on this one, took the crown off. This is how she came. The dentist just cemented the temporary crown to the teeth either side. We took it off. We started preparing the socket shield, thinned it down from this shape to a crescent shape, placed the implant. This time I made sure that I took out the root apex. I only made that mistake once, and you won't do it again once you've done it once. And again, we placed the implant in a more palatal and apical position, and we fill the defect with a graft. And you can see here, and then we start temporizing, making a temporary with a temporary abutment. And this is how she left, okay? And we just wait for the soft tissues to fill in. 2 weeks later, she comes back. Even in 2 weeks, you can see how the papilla was here, and in 2 weeks already it started filling in because we have a really nice temporary crown, nicely shaped to allow the soft tissues to creep down into the gaps. So you can see how it was there, and you can see how it's already looking. And when you see stippling like this above an implant, you can tell that it's going to work out and be a good long-term successful result. You can see the soft tissue profile when you're looking from the occlusal view as well. And this is how it looks with the temporary tooth. And again, another one where we had already an implant, and I knew that if I removed the lateral incisor next to it, we're going to be left with literally no soft tissue profile at all. And so again, I used this case as a socket shield. And you can see here that the crown was already actually coming out of the tooth. We prepared it. Look at the soft tissue profile before we started. That's what we don't want to lose. So we actually maintain it by keeping parts of the root there. We place the implant in a palatal position, temporary abutment. Sometimes I like to pre-make a shell crown. My technician pre-makes these. You saw earlier, I use this as a guide in an Essex retainer, and I drill through the crown. And then I use the same crown because it's already nice and polished. It's already got the correct shape and the shade. So I don't have to sit and do too much. It makes it easier for me, and I just do a pickup. You just pick the temporary abutments up. You fill the gaps here. And you can see here, I just put like a little something inside so you don't get any material inside. And you do a pickup of the crown. And then you shape it in the usual way. Comes out like this, and you start shaping that part there. And then you get cases like this where the patient comes in with a large defect. And my friend referred this to me, and she was asking him for an immediate implant. And he said, it's okay, my friend can do this for you. He can do an immediate implant, and he gives it to me. And I looked at this, and I phoned my friend up, and I said, what are you talking about? There's a massive area here. But then I saw the patient was so demanding that I just said to her in the end, I'll do my best. So we ended up taking the tooth out. You can see that the dimensions of the teeth were wrong to start with. So we took the tooth off. We did a socket shield on this one. I just tried. I thought, let me go through the motions. We took out the palatal part. Again, definitely took out the apex of the tooth. We did a crescent shape, and then I just did a little flap at the top to actually remove the cyst in the apical part. And then we grafted that. We placed the implant. You can see, if I showed you this x-ray to start with, you would have said, what's he done? Why is it so close to this tooth? And you can get away with an implant being close to the tooth next door if the original tooth was that close to start with. If there was no tooth here and I prepared this implant that close, we might have had problems. But when the original tooth is that close, you get away with it, okay? Because there's a thin layer of bone, and already you're not actually preparing anymore. You're not drilling next to the periodontal ligament of the next tooth. So you can see that the tooth was here, and the implant went in the same position in this area. And we grafted here with, actually we used beta-tricalcium phosphate graft material. And this was it when we sutured up. And, sorry, there's one photo. And this is how she came in 12 days later. So you can see, you can't even see where the trapdoor flap was after 12 days. But you can see how well we've maintained the soft tissues around here. We've actually brought them down a little bit as well. And just the last case, just to quickly run through, again, a post-crown that was in position, and this fractured, and the dentist made a new post as a temporary. And again, there was a post in here, so we had to start creating the socket shield anterior to that. But look at the soft tissues. This is what we want to keep. The patient came in, the dentist made yeah, this is the last one. Oh, she already had a temporary denture made. Usually I would have done an immediate crown. Sorry. So we prepare the root membrane, crescent-shaped, place the implant, graft the buccal gap, but look at the soft tissues here. This is what we don't want to lose. You graft the area, and then this is at review. So you use something small, and you allow the tissues to grow over, but look at the maintenance of the soft tissues. And this was how she came in. This is actually the denture. It's not a temporary crown. So there was first partial extraction therapy consensus with all the names that were there. And they basically, in the end, said socket shield is here to stay. We now have 10-year data and longer. But the main thing that was pointed out, it's not for the novice surgeon. And the problem with social media, you learn new techniques, but people see that this is being done, and they try and do it themselves, thinking that doesn't look too difficult. And believe me, when you see some of the people doing it, like Howie Gluckman and Maurice Salama, they make it look easy, but it really isn't that easy. So it is a technique. It's a bit like all-on-4. Is every edentulous case an all-on-4 case? No. We know that it can work, but it doesn't mean every case is like that. And the same thing with socket shield. Not every case is going to be done this way, but it's one of your tools in your armamentarium that we should think about using for the right case. So thank you very much for listening to me, and this is my email. If you have any questions, please do feel free to give me a ring. Thank you.